So first, I'm just going to introduce our panelists. So first, we have Angela Erickson. I'm pointing to her as you guys can see who I'm pointing to, but it's where she is on my screen. She is PLF's Strategic Research Director, and she works with all the staff and the attorneys to create and manage, the social science research they do, which is plentiful, and I'm a big fan. And she specialized before this time. She actually worked on occupational licensing with the Institute for Justice. So she's really in this regulatory space and knows this world all too well. Matt Mitchell, who Matt and I go way back to our time at Mercatus. He's still there, research fellow. He's a senior research fellow and the director of the Equal Liberty Initiative. He's also an adjunct economics professor at Mason. And if you followed Con, you know who Matt Mitchell is, because the last 6 years, he's led Mercatus's research on this issue. And it's amounted to, change in dozens of states talking and taking up this issue, which has come in the way of research, policy briefs and commentaries, testimony. And in 2020, this work actually earned the team that he's working with there, Atlas Foundation's North American Liberty Award. And finally, last but not least, Alicia Plemons, hi Alicia, wave, is an assistant professor at CAS undergraduate economics program director in the Department of Economics and Finance at Southern Illinois University in Edwardsville. And she's also a research affiliate at the Knee Center, which you would think would be for broken knees, but it's not. It's actually the study of occupational regulation at St. Francis University. And she currently leads a medical licensure research group in investigating the roles of scope of practice and certificate of need laws on pandemic recovery. If you haven't seen her paper on this, it's fantastic. I read it. A lot of good stuff that is so relevant for the time we're in right now. So just to kick us off, Matt, why should we care about con laws?
Well, thank you so much, Kathleen. Thank you to PLF for organizing this, and to all the panelists. I'm really excited about this opportunity. So we should care about it because, there's not a lot that the left and the right agree on. But if you look at what their general statements and their platforms on healthcare, they're basically in unison in terms of the goals. The goals are greater access to care, higher quality of care, and lower cost of care. And when you look at states that have con laws, we have this, in some ways, it's a nice natural experiment. We've got 15 states that don't have con laws. About 38% of the US population happens to live in one of these states. These are rural states, urban, coastal, intercontinental, rich, poor. You can control for all these other potentially confounding factors, and you can compare what's going on in these states relative to what's going on in con states. And on those three measures that both left and the right seem to care about, it appears that outcomes are worse in con states. Patients have less access to care. The care that they do access is of lower quality, and the costs are higher.
Perfect. Thank you, Matt. So can we go back to this whole idea? You said that 35 states and DC have con laws on the books right now. I think you also said the federal government stopped requiring this. So why is that? Because I think it's hard to find something in healthcare the federal government's not touching. Mm-hmm. And do states really have the power to eliminate these?
Yeah,
so
the state con experiment began in 1964 when I think it was New York was the first state to adopt a con law. But it really got its push in 1974 when the federal government passed the National Health Planning and Resources Development Act. And one thing that's nice about the act, by the way, is in the first couple pages of it, they're quite explicit about the goals that they want to achieve. And you still see these goals echoed in the regulations and the statements of con boards about what they think they're doing. It was to increase access to care, which is weird. I don't know why decreasing supply would increase quantity supplied, but that was a goal. Increase access to care in rural communities, increase access to care for underserved communities, encourage hospital substitutes like ambulatory surgery centers. That's also weird because a majority of the con states now have a con for ambulatory surgery centers. Increase the quality and decrease the cost of care. So that's where it came from. But by the mid-1980s, I'd say that there's really two reasons why the federal government reversed itself. One, the initial studies just like the current studies, suggested that it was backfiring, that it actually seemed to increase costs. It was certainly decreasing access to care. And I don't think at that point there were too many studies on quality, but it seemed on those two dimensions, at least, it was already failing. And then the second reason is the federal government changed the way it reimbursed for Medicare. And so they felt previously it had been called a cost plus reimbursement scheme, which basically was, hey, tell us how much you want to be paid and we'll pay it. And so that really did kind of change the impetus there for quite a bit. So in 1987, I think it was, Democrats in Congress and a Republican president came together and eliminated the federal mandate. And the federal mandate, by the way it had worked is it had withheld federal funds from states that didn't adopt these types of programs. So they eliminated the mandate right off the bat. About 12 states repealed, and over the course of the following couple decades, there have been a steady trickle of a few more repeals here and there. Pennsylvania, New Hampshire is the most recent outright repeal. And then one nice thing that we've seen is a lot of states have pared back their con laws, even if they've kept them on the books. Florida is probably the most significant recent example of that.
Great. And Angela, I'll go to you. You kind of worked with this also in your occupational licensing work. What's the holdup? Like, right, the feds aren't required. There's a lot of research saying this actually has reversed outcomes. And we're saying, who's fighting for these and what's holding states back from actually changing these laws?
Yeah, so as Matt said, right, there's more than 4 decades worth of research that shows that it's doing the opposite of what it was intended to do, right? Costs are higher, there's less access, they're disproportionately affecting minorities, rural communities. It's really, even quality of care is being reduced. And so, why does this still exist? Why haven't states removed it? And what it really comes down to is a really powerful force that wants to keep them, and that's the hospitals, right? As Anastasia introduced it, this is a competitor's veto. And the competitors in this situation are the people who already have cons, and the strongest ones are hospitals and the hospital associations. And so there's a little bit of research out there that's actually looked at the hospitals and sort of how they benefit from this. One study found that CEOs of hospitals in con states earn more than $90,000 more than CEOs in non-con states. Take a moment and think about that. $90,000 more is more than an average American makes. There's also there's some research that links campaign contributions to certificate of need approvals. So there's clearly a lot of political incentive for the hospital associations to lobby and for legislators to acquiesce. And that's going to be a big hurdle going forward in changing these laws, and is a hurdle that people who have been trying to reform these laws have really been facing over the years.
Thanks, Angela. Now let's shift over to the pandemic, right? The pandemic, everything changed, and there was a lot of movement on this. What happened to con lawyers during the pandemic? Did states kind of do this within their state of emergencies? How did it play out?
Yeah, so transporting everyone back to March and April, which I'm sure we're happy to go back to. Essentially, immediately, states recognized that these laws were in the way of them expanding care. So within that first month, at least 19 states suspended or set up emergency con provisions. So they suspended it typically for something like hospital beds. So in a lot of states, you need a certificate of need just to add hospital beds. In some places, they suspended it for something more broad, anything related to COVID-19, right? And so those were in the really early days. Most of that was being done by governor's emergency orders, some by departments. There was some really interesting stuff also happening at that time in a few states. Indiana only has a certificate of need for nursing homes, and they suspended it for that. There's another state that suspended it for nursing homes and long-term care. So thinking about the extended effects of COVID-19 on other populations besides inside hospitals. And then there were a few states that actually have what are called emergency provisions built into their con laws. Most states don't appear to have these. The ones that do, they've been using them for the most part. But these are also really poorly written. So we're thinking about like how to reform con law. A lot of these emergency provisions aren't written for something like a pandemic. So in the case of Kentucky, which is where I am, so I'm going to mention it a lot because I just pay more attention to where I live. So in the case of Kentucky, it's written for if someone, an individual person needs to be transported to another hospital for some reason, say they need a different doctor or something like that. And so an individual hospital would apply to get whatever equipment they need to then be able to house that person in their facility. It's not written for something like a pandemic or some other sort of situation that requires multiple people to have, be part of the process. And so they're really not written for this type of situation. And so in the first month, it was really people across the board, about 24 states in total suspended their certificate of need laws in some way, to some extent.
Oh, that's amazing progress. I want to go over to Alicia because you actually put out some fascinating work. I put it, well, actually I just sent it to Naomi, but I'll put a link to it in everywhere so everybody can read it. But basically looking at a simple question, how did states with con laws impact COVID-19 deaths? What did you find?
Yes, this was the topic that everybody kind of wanted to talk about. So it was really timely that this was the time when I started realizing, wow, con laws are interesting. Why do these even exist? So for everybody who doesn't know me, my name's Alicia. I see a lot of familiar faces, and thank you, Kathleen, for moderating and having me out today. So what I was working on, especially during the summer and that I've been updating recently, was just looking at what's happening to mortality, right? What's happening to the people that need medical equipment right now when hospitals are limited from being able to purchase this sort of equipment. Because when everybody thinks of con laws, they think of building hospital wings, but what they don't realize is that this also impacts beds inside the hospital, beds outside the hospital, facilities, services that you could give, all the way down to, are there enough respirators within your hospital in some cases? So what I looked at was I compared states with con laws to states without, and then I looked at the states specifically that repealed their con laws in the March or April period of time and saw what happened to their deaths afterwards. What I found out was that they had a pretty substantial reduction in COVID deaths, about 11 people per 100,000. So that's great. But the other interesting part that I found was what happened to non-COVID patients. So COVID patients were competing for similar resources to things such as extreme cases of chronic lower respiratory disease, different types of septicemia, and all these other different sorts of lung affecting diseases that also needed oxygen, intubation, respiratory care. In the states where they ended up repealing con laws, so the hospitals were able to buy more of these services, more of these equipments, we saw that deaths actually reduced for these sorts of groups as well. So not only was it helping with COVID patients, it was helping with patients that were competing for similar resources. One of the things that we noticed in the con law states that were not willing to repeal their laws was that they were borrowing equipment from other departments, and this was affecting the longevity and the mortality of the non-COVID patients.
Great. And Tyler had a question in the chat I want to address. And I think you covered this somewhat, but of the states that suspended con laws, are there any studies being conducted on what happened during that time of suspension? I think you addressed some of that, right? You saw lower deaths, more, especially in some of those non-COVID cases too. But is there anything else you want to add to that of just the effect of non-con states versus con states?
Sure. So I think one of the reasons why some people may not have saw an initial effect is because they didn't look at hospital capacity. It was the states that were really already constrained on their hospital capacity that when they repealed the con laws, they saw the largest amount of benefit. There's a lot of studies that are being conducted. Pretty much look at anything coming out of Mercatus because they have a lot of publications on this right now that look specifically on what's happening with this repealing part. I know that the two people that I'm working with on the particular paper that people have been referencing, Shaparna Ghosh and Roy Chaudhry, have been looking a lot at what's happening specifically during this period of suspension. So that's something I'd love to talk more about if you're interested. I don't want to hold us up.
Great. Well, let's keep going and keep digging into that a little bit more. But one thing I wanted to go over to Matt, because you did some research specifically on hospital beds, right? Which one of the big things we've heard this whole year is, right, the need for hospital beds is going to be critical, and ICU beds in particular. Were hospital beds just harder to come by in con states? Like even if they took action, was it harder to come by in the first place?
Yeah, that's what we found. So one thing is we were looking at, we did a study in the spring, right as COVID was sort of starting to ramp up. I think it came out at the end of April. And at that point, all we had was projections of hospital bed shortages. So we used data from the University of Washington's well-cited data about, essentially estimates of which states would run out of hospital capacity. If you think of the idea of flattening the curve that we've all seen, this is the part of the curve that's above the bar, right? And the narrative on COVID, by the way, has, as you all know, has changed a little bit over time. But the initial idea of flattening the curve, if you think in terms of calculus, is that the area underneath the curve is not going to change, right? It's just that we want to flatten it so that we're not all in the hospital at the same time. Now that we have vaccines coming out, hopefully the area underneath the curve will actually fall. But in any case, so our thought was, what part of that curve lies above it? And what we found is, yeah, absolutely, the states that have con laws are significantly more likely to experience shortages, and they're more likely to experience, or at least estimated shortages, and the shortages are going to be larger. The factors of a difference are really enormous here. We're talking about an average shortage of 114 ICU beds in a non-con state, but an average shortage of 8,000 beds over the course of the infection in a con state. But here's the thing. As it turns out, a lot of that data ended up being a little bit more pessimistic, thankfully. We did not experience as many shortages as we thought. So now we're just in the midst of looking at the actual data, not projections of shortages, and to see how many beds how many states experienced either a shortage in ICU beds, or at least a shortage or at least bumping up towards the capacity in excess of ICU beds. Because one of the things that's coming out is that we see that as states got closer and closer to their capacities, people reacted, doctors and triage nurses reacted, and they did their best to unfortunately, not care for other patients because they didn't want to fill up beds. I mean, that's a rational choice to make. And so, essentially what we're finding is, sure enough, states that did not have, or states that have con laws, were getting closer and closer to that capacity relative to other states. Thankfully, it does not look like the capacity shortages were quite as bad as everybody projected, though.
Okay, some good news. All right, and this is something I would love all three panelists to respond to. As we go into 2021 legislative sessions, I guess they're here. Probably there's going to be a lot of chatter of, should we do this or not, or should we remove certificate of need laws just for the pandemic? Was it just needed during the pandemic to get beds where they needed to be? What would you say to a lawmaker or somebody in the state who's saying, no, we need to do this because it's good for all the time, not just during the pandemic? Let's start with Matt, then we'll go to Alicia, then Angela.
So in our initial study, this is somewhat of a difference between what we found and what Alicia found, is we didn't find that there was any difference in states that had repealed con laws versus states that had not. And I think it's just a matter of we're looking at slightly different measures. But part of what I think is going on here is that hospital capacity takes months, years, maybe sometimes in some cases close to a decade, to build. So if you repeal the law, that's great. You might be able to get a few more of the highly, elastically supplied services, but you are not going to be able to quickly build the capacity that you need to really stave off disaster. And I think part of what we're seeing here is just the illogic of the idea that a central planner can really know what the capacity is, at least the needed capacity, any better than entrepreneurs who are responding to actual market signals.
Great. Alicia, how would you respond to that question?
Sure. I agree with Matt on a lot of pieces. With con laws, a lot of the time it's better to prepare in good times for the bad times, right? it was great that these states repealed their laws. Though we measure it differently, there might have been some outcomes for that. But what if these hospitals had been able to stockpile needed equipment for a pandemic in a non-pandemic time? That's probably the one thing that would have made the biggest effect. But we're not going to see that because many states just did not have this capability. So I think having, the voice of reason of this might not be the first pandemic. They're already saying that we might have more coming out in the coming decades. This is something that we might need to prepare our healthcare infrastructure for, so we don't see some of the sizable effects that we saw now. And if we let hospitals prepare during good times, I think we would have seen a completely different outcome. And that's what I would tell legislators.
And Angela, what say you?
Yeah, I agree with a lot that Matt and Alicia have said. I think the key is that we can't anticipate the future, and con laws prevent healthcare providers from being innovative and flexible, right? Like there are lots of things besides beds and that were a problem in the beginning, right? We didn't have enough ventilators. In some states, you had to have a certificate of need to have ventilators. There weren't enough ambulances, so EMTs were waiting with patients for hours waiting for someone to come to a home, and they were contracting COVID because of it. I mean, even something, you think of the system as holistic. Matt said there were a lot of people that weren't getting care, right? So like during this time, there were a lot of people who had to forego cancer treatments and other things that they shouldn't have had to. And so you can think about allowing that type of innovative flexibility allows you to move people around to better cope with something like this. So something like, we'll talk about it this afternoon or the next session, but birthing centers are a great option to move healthy pregnancies out of hospitals, right? And put them somewhere else so that those beds and those nurses and doctors can be focused elsewhere. And so when you have cons and you're thinking just of the pandemic, you really fail to capture that this is a really big system, that there's a lot of moving pieces and you can't control it from the top down.
Great. That's all super relevant. So it's definitely important, and we should make it a priority for all the reasons you all just said. Naomi put a good question in the chat. She mentions that one of the things she's seeing in states is that they're reducing bed counts for a couple of reasons. One, they're basing numbers of bed on adult beds only, and two, they're basing number of beds on available staffing, which is a big issue that I'm sure a lot of states are dealing with right now, just the staffing, medical staffing. How could these changing counts affect con education and strategy? How do we take that into account as we're going into sessions?
You want either of us, or where do you want to start?
Anybody who has a thought here can.
Mine's short, and then I'll pass it back over to Matt. Con laws aren't a one-size-fits-all policy, right? It's not the one policy that we can change and everything magically gets better. I think we need to pair that along with scope of practice. Are we allowing people to be able to move in between different types of places? For example, birthing centers. How can we make sure that they're allowed to see a diverse set of patients, or patients that have different types of circumstances besides, the ideal perfect pregnancy, or lots of other situations like this. So I think if we're going to change con law, we're also going to have to change some scope of practice to make sure that other types of facilities have the equipment, training, and ability to see patients that we would like to be able to expand.
Great. Angela, Matt, anything to add?
I guess I'll just add two quick things. One, just it's a good point that capacity in one area affects capacity in all sorts of other areas. All of us have probably been at a restaurant where they won't seat you, and you see open tables. You say, "Why can't you seat me?" Well, it's because they don't have the servers to staff those tables. So there's no point in seating you if you can't actually get some food. So I think that's a lot of what's going on here. The other thing is maybe it might be worthwhile just pointing out some of the metrics that they actually use to evaluate a con and why it's sort of nonsensical. So the basic metric that they'll use is they'll say, well, you, Kathleen, want a con. Well, what we're going to do is we're going to look at the existing hospitals in your area and see the average bed capacity over the last year. So a couple of things about this. One, of course, it misses the possibility that there could be unforeseen spikes in bed capacity, obviously a pandemic, but also there are, unforeseen emergency medical mass medical events, hurricanes and terrorist attacks, things like that. It's hard to plan for that. But a couple other things. Another one to think about is, okay, let's say that I'm your competitor. I'm already in operation. I know that you're more likely to get your con, Kathleen, if it looks like my hospital bed capacity is getting real high.
Mhm.
So that gives me an incentive to make sure that my hospital bed capacity doesn't
Mhm.
get full utilization, to keep it down. Ironically, this gives me an incentive to make sure that I have lots of unused beds, which is exactly the opposite of what con is supposed to achieve. And then the other thing to point out is think about patients. So, imagine you've got another, you've got a patient, let's say Alicia is a mother who is going into premature labor. She's probably done her research and is going to check to see, well, does Matt's hospital have a NICU unit? And if it doesn't, say because I've been denied a con, she's not even going to show up and ask for it. So she's not going to appear in either the numerator or the denominator. And so the state, in evaluating this, their numbers are totally uninformative. They're not going to really tell whether whether Alicia needs a bed or not, because patients are smart and they do some of their research. So anyway, the basic idea of just trying to look at hospital bed capacity really misses so many of the nuances of what really is a determinant of hospital bed capacity.
Great, thank you. I also want to just go into, so I think it's always good to look at where has this been done and what can we learn from it. So as you look at your research, and Matt, I know you've done a lot of state by state research. Who are the states to emulate here, especially in recent history? I know there was a lot in the 80s that kind of just said, oh, we're done. And there's a lot to be told from the ones, what we've learned from the ones who haven't done it for years, but who in recent history who has done this? And what are the things we should look out for and emulate from those states?
Well, I want to be careful not to step too much on the topic of the next panel, but there's a couple of different ways that states can go about it. So one is, if you look at New Hampshire, they did an outright repeal, but they understood and recognized that that hospitals would find that outright repeal difficult, right? And so they phased it in over a period of 5 years. And the way they did it, it's not quite phasing in. It's that I think it was around 2013, they said effective 2018 or 17, there won't be a con law. So it was a immediate effect, but it wouldn't take effect for a few years. So that's one way to do it. What I would suggest is, nobody's done this, but why not order the con board to, let's say that they've approved 50% of applications last year. Let's just order them to approve 60% next year, 70% the following, 80, 90, until they have to approve 100% of all applications and close up shop. I think there are, that among many other types of nuances, there's lots of different ways to do it. The other pretty popular way to do it is to reduce the number of services that require a con. And Florida is probably the best example, where they no longer require a con for general hospitals switching to specialty hospitals, or specialty hospitals switching to general hospitals. They no longer need a con for new general hospitals. They've eliminated the con for all sorts of specialties hospitals, from children's hospitals and women's hospitals, et cetera. They've kept the cons for nursing homes. And unfortunately, most states tend to do that. I don't exactly understand why, but for whatever reason, nursing homes are just extraordinarily effective at putting the political pressure on policymakers and keeping those. So there's a lot of different ways to do it.
Great. And has any of your research, Alicia, I know you looked at did you look at nursing homes in particular when you were doing this research around con versus non-con states? And I mean, we've heard a lot of the news has been the nursing homes have been a big source of mortality during this pandemic.
Mm-hmm. I haven't looked at nursing homes myself. I know that that's something that people are interested in, and I know a few people who are currently working on it. So I bet research will come out in the coming time, but it's something that I didn't look at. Now, I do want to piggyback off of what Matt was saying about the states, though. Some states did repeal con laws. So they've tried phasing them out and things like that. But there's one state that people don't talk much about, and that's Maryland. So during the pandemic, Maryland didn't have to go through the same executive order process that all the other states did, because they already had a well-defined way of having their hospitals go through the process of declaring that we needed an emergency certificate of need, and they were able to get the things that they needed. They didn't do it till April, but they still had this availability. Some states are not going to be willing to get rid of their con laws immediately, right? They have a lot of pressure. They have a lot of lobbying groups, especially from nursing homes, from hospitals. They don't want to get rid of it immediately. But one way that we can at least start the conversation is saying, hey, how about we put in at least these well-written, well-defined emergency provisions, so that when things start to get bad, it's at least flexible enough to pivot. So that's something that I think more states should probably look at if they're unwilling to repeal at this point.
Great, thank you. Well, I want to go ahead and start turning over. So go ahead and start putting your questions in the chat, or feel free to just put one of the emojis up, maybe the thumbs up. They should have a raise hand feature on these emojis. Put that in the chat. I'll call on you, or feel free to just speak out. We're all friends here, right? So before we move on, I want to just say, what have we seen from other industries? Is there good lessons learned from this? Angela, I know you've worked a lot on occupational licensing. There's some similar ties here, right? About the competitor veto and the who decides. What can we learn from those industries that have gained more progress over the last few years than con has?
Yeah. So we typically think of certificate of need in the healthcare industry, but it actually also exists in other industries. And so it's typically called a certificate of need or a public need and necessity. But it exists in utilities and transportation and elsewhere. And today we just launched a report on it in the moving industry context. It also exists for taxis, limos, van lines, and I think a couple of our panelists this afternoon will talk more about that. But PLF and IJ have a history of fighting those particular certificate of need type laws. And so there's lots to learn from the fight of those, but there's also some to learn from the outcomes of those. So the report that just came out, though we weren't able to measure sort of a difference in sort of the number of providers among states, there was clear anecdotal evidence in some of the states where it was really being enforced that there was a vacuum of supply. And so for those of you who are at our December panel event, Raleigh Bruner talked about his experience here in Kentucky as an entrepreneur opening up a moving company in Lexington. And we represented him and ultimately got the laws removed from the books here in Kentucky. And what happened after that is he started not only continuing to operate the business he had started in Lexington, but he opened a business in Louisville. He opened one outside of Cincinnati. This was about 6 years ago, they have more than 50 box trucks. They do about 10,000 moves a year, right? So there was a supply need that was not being met. And something to keep in mind in the transportation context versus healthcare is the substitutes are less costly than healthcare. So if you need to move, you can move yourself. If you need surgery, you probably shouldn't do it yourself. So there's some things to know that it's clear that there are going to be innovative ways that people will come along and do it. And the sky doesn't collapse in these other places where they've removed cons in other contexts. And even the quality of service doesn't change. I've looked at Better Business Bureau reviews of moving businesses, and they're the same in states with con laws and without con laws. So it really has no effect on quality. And it's really just there, as Anastasia said in the beginning, to help competitors, right? It's as a competitor's veto. And it had operated that way in a lot of states that PLF had fought, and we saw that any protested applicants were denied. And we see that a lot in healthcare as well.
Perfect. Now I want to turn it over to just some group discussion, what questions you all have, maybe things you're seeing that you want to discuss, because I think we're all here for the similar reason, is that we see these con laws on the books, know that we need to remove them, that it's actually going to help patients, it's going to help with costs, it's going to help with access, all these things that we care about in healthcare. So what thoughts, questions, follow-ups do you have to all this? I want to hear from you. Now, I will request that you don't all ask at once. So. Well, let me throw out one to. Yeah, please, Anastasia.
Yeah, I was just thinking as we're talking about all of the good research on our side, and I am aware that, you know, the research is overwhelmingly with people who support reform, but I'm wondering if we can talk about or address whether there is in fact any research that goes the other way, and what it says and how we can address anything that goes against us.
Great question. Great.
Hi, this is Naomi. I'll take a quick stab at that, Anastasia. So one of the things that I'm seeing at the state level, there's certainly a lot of enthusiasm for removing con laws, but what you have the hospitals responding with is, look, this is an emergency, a pandemic, and in order to make sure that we do have beds in the next crisis, you've got to make sure that that you've got the payment systems in place, that you don't have areas that don't have any beds. And I mean, obviously these are bogus claims and arguments, but that really is, I think, what scares state lawmakers whenever they're getting this issue in front of them. So my two big thoughts, though, on con reform are, I think, a much broader approach that integrates a lot of the issues that relate to the supply side of healthcare are really important when going after con. And I think, you know, that's probably very broadly recognized amongst our groups. The other thing, though, that I'm seeing that's really exciting is I actually think that con reform is becoming far more irrelevant every year. And the reason is that you've got these private sector companies that are working with self-insured plans who have really great claims data. And we also know that these self-insured plans have less churn. You have fewer people jumping in and out of those those insurance groups. They are able to know how many knee replacements, how many rotor cuffs, how many stents they're going to need every year. And so they're pre-negotiating the number of services with surgery centers. And so I think that as this space continues to grow, and it's growing, you know, pretty rapidly, and we know that, you know, the self-insured space, you know, they're really, you know, those employers are actually paying directly. There's not really a true insurance model like you see in the rest of the insurance space. It's more of an umbrella catastrophic policy. They get, you know, underwritten with that. So I think that, you know, really understanding that aspect of the market as well is going to be really important in how we look at strategy and where we put, you know, where we're putting our resources on this particular issue.
So that's great. I think that's a great point, Naomi. And I think the general question is absolutely the right one, is we should be very aware of the types of arguments that con advocates make. And that's partially what's kind of, I think, driven our research in the past. And so let me just address a few of them. Probably the most common argument you hear is hospitals are in trouble. You know, they'll just say, they'll often point to data that there are disappearing number of hospitals per capita. Gradually, hospitals per capita have gone down in our state. And so we need this to help them. So a couple responses to this. One, we should note that hospitals are disappearing around the country for various reasons. One of them, not all these reasons are bad. Patients tend to find the ambulatory setting to be better than the large institutional setting. And so as ambulatory surgery centers have increased, hospitals have decreased. But the other thing is, the basic premise behind this is, there's a supply problem, so we need to restrict supply. And so just the very kind of on its face, it doesn't make a lot of sense. And in fact, the data that find that there are 30% fewer hospitals per capita in con states relative to non-con states is driven by the fact that the declines in hospital capacity actually seem to be greater in con states relative to non-con states. And then another somewhat related is this cross-subsidization argument. And I'm somewhat sympathetic to this, but the basic idea here is, hey, we hospitals, we have these really expensive mandates. We have EMTALA, which requires us to serve anybody that walks through the door. ambulatory surgery centers, they don't have that. They don't have to serve anybody who walks through the door. And so they'll use the phrase cream skim. They get to take all the well-insured patients away from us, and we're just left with the folks that don't have any insurance and aren't going to pay. So 2 responses to this. One is just to point out what a Rube Goldberg scheme this is. The idea here is, okay, we want Matt, his hospital, to serve a patient who walks through the door who's underinsured. Let's say that that's Angela. So what we're going to do is we're going to give Matt a monopoly and hope that he charges Kathleen, who's well insured, a lot higher price, and then somehow transfers some of that money over to Angela or gives Angela a deal. It's a very complicated scheme. A much more direct way to do it would be to just say, if we think that the state owes it to pay for indigent care, then the state should subsidize Angela's care. But 2 is, again, go back to the data. The data belay the point. As it turns out, there is no greater incidence of charity care in con states relative to non-con states. So the uninsured and the underinsured are not getting any better care thanks to the monopoly, to giving monopolies these privileges. So it turns out the Rube Goldberg scheme doesn't work.
Yeah, I totally agree with every single point you made. My bigger point was just along the lines of strategy. Right now, in the time of COVID, you will not find a state lawmaker, even one that really agrees with us, who's going to, I mean, maybe you might find a couple, who's going to lead the charge on con reform in a state house when you have physicians and hospital administrators, really like in tears over what's happening at their hospitals. And I realize that hospitals have been bad actors for decades. They are bad guys, but right now, some of their tales of woe are actually true, and it's going to be a much harder sell. And so I just think that we need to spend, I think that focusing on the great con arguments are not as compelling today as they were, say, 1 year ago.
I think, Naomi, you even 1 year ago, I think you would have been correct. I was chatting with a hospital lobbyist at an informal meeting a couple of years ago, and I asked her what she thought about certificate of need, and she's like, it's great. And essentially that it helps them pay for indigent care or charity care. And this is a hospital group that works both in Kentucky and Indiana. And I was like, well, what about in Indiana where it doesn't exist? Why is Kentucky special? And just essentially argued that, oh, it's because we wouldn't be able to serve the rural communities if we didn't have the hospitals in the urban communities and didn't have that monopoly, essentially. But it doesn't make sense in terms of why it's different, right? And so a lot of the conversations that I hear happening with the hospital associations behind doors or in less behind doors, but it's essentially he said, she said, even if the facts are on our side. And so it doesn't take us anywhere. Whereas I think Naomi was spot on with when they have fear on their side, because they are the ones actually doing the things and you can't see the unseen. And so how do you convince a group of legislators or lawmakers that it would be better? The world would look better in this unseen world if we got rid of con.
So that's where I do try to emphasize. I lead with the point of, hey, 38% of the population lives in a non-con state. We don't have to imagine what'll happen. Just look at their experiences. 2 other quick things that are potentially on the strategic point is use the American Medical Association whenever you can. Hospitals themselves, of course, tend to favor con unless they've been stymied by it, but the doctors do not. So the American Medical Association is on record opposing con laws. And then 2, well, actually maybe 3. 2, ambulatory surgery centers are a great ally. They tend to be small entrepreneurial business owners. So they're going to tend to be on your side. And then finally, the Federal Trade Commission and the Department of Justice, they're willing to come in and talk to your state legislators about how these are anti-competitive laws. So I think that's helpful.
Oh yeah, no, absolutely. I mean, what I see happening over and over again is in states, you might get some lawmakers who will come out and say, oh yeah, we want to get rid of these con laws. But what they're really talking about is allowing for bed expansions in already licensed facilities, excluding ambulatory surgery centers from those types of potentially positive reforms. And so I just think that, you know, we've just got to be very careful and understand that COVID has dramatically changed what the concerns are around hospital beds and capacity. And right now, our free market liberty movement and our allies, who are fantastic and wonderful, and there's, I mean, you know, obviously the truth is absolutely on our side, but the narratives are not playing very well right now today. And that's what I'm saying. And I think that's why a more umbrella approach to healthcare reform is probably a lot more helpful right now.
Yeah, so doing this as a suite of things, here's all the reforms we need to do to be ready for the next time. That's what you're saying, Naomi, right?
Yeah, and you know, and you know, and part of it really is that you know, being right is you know, it's wonderful, but it's not moving the needle, I think, for lawmakers who are very scared, where hospitals do have an enormous amount of muscle and can easily scare lawmakers. And really, you know, I think and I don't even want to say watered down, that's not the right word, where they can actually change what we want to do and pervert it into something that's actually even more anti-competitive in the name of, you know, con reform. And that's what I really worry about on this particular issue right now, because we are in COVID and because of, you know, the fear that we see in lawmakers.
Good points, Naomi. One thing that, I mean, you touched on, like, it's going to be a hard road on this. Who are the allies? I saw Maura Tannenbaum posted this statement from the American Birthing Centers. They might be an ally, but especially to some of those of you who have fought this on the ground. I see Sal's here from Florida, and Matt, you mentioned Florida earlier. Who are the allies? Who do you need to start talking to make this case? So as Naomi said, it's not just, you know, free market groups who maybe don't have as much of a say, right? They're like, who are you just as researcher? We're going to hear from the people on the ground delivering healthcare. Who are those allies, and who are those relationships that needs to be formed to get this done?
Hey, it's Sal. If you would like, I can give a little bit of perspective.
Sure.
We were really fortunate in Florida in the 2019 and 2020 legislative sessions to have two really big allies, and they were unique, or in a sense, kind of the stars aligned. One was our House Speaker made market-centered healthcare reform a priority of his. So that was one of the things that he made a big deal about going after. And he actually called them in his first speech during the kind of state of the state when he took the gavel as speaker. He called them the healthcare industrial complex. So he had it in for them. The second thing is that we have an amazing AFP state chapter in Florida. And so kind of the secret sauce was we did a lot of the wonky stuff and wrote the papers and spoke a lot of the same kind of messaging that y'all have spoken about for the last, you know, hour. And AFP went and dropped their bombs. They went and did mailings, and they did postcards, and they called out the Senate and whatnot for not moving forward with it. And eventually it just became something that they couldn't stop anymore. So it was a combination of those kinds of things. And one of the things I'll point to also is, and this may be for folks who are from other states that are looking at this, one of the things that helped us was we had some research, and it got broken by a political media guy, that of the 40 Florida senators at the time, about 13 or 14 of them were either directly employed or their spouse was employed by a hospital. And that helped frame a narrative in a way that helped drive a little bit of the fence sitting into our corner. So those are the things I would highlight from the Florida experience. As Matt had mentioned, we still have the nursing home and hospice cons left, and the ambulance one, although that was set aside by an executive order. So we still have some work to do, but you know, we'll keep fighting those.
I really like Sal's focus, I think this grassroots piece is really important to get essentially something like a patient association or a doctor-patient association to say, right, the hospitals have their own incentives. We are the people who are treating and need the care. And this is what our experiences are like. And so having a very strong competing emotional voice, I think, is helpful.
Yeah. And Matt, oh, we can't hear you, Matt. Still no.
How about now?
Yeah, now it's great. Yeah.
Okay. I think it's also good to tell stories. You know, I being an economist, I find stories somewhat anecdotal, and most economists kind of like poo-poo them. I'm more compelled by the data. There's 30% fewer hospitals, 30% fewer rural hospitals, 14% fewer ambulatory surgery centers, 14% fewer rural ambulatory surgery centers, fewer hospice care facilities, dialysis clinics, all that stuff. But stories are compelling, right? Humans really, react to stories. And so I'd encourage, particularly any of those who have investigative journalism type branches in their think tank, to do some investigative journalism work. Eric Boehm has a wonderful, I'm sorry, that's probably not the right adjective, has a very compelling piece about just a tragic case that went on in Southwest Virginia, where the story is there was a Lewis Gale is a hospital in rural Southwest Virginia. They applied several times for a con for a neonatal intensive care unit. Several times they were denied. And shortly after one of their denials, a mother showed up with, she was in premature labor. There was complications. They didn't have a NICU unit, so they called the nearest hospital in Roanoke and asked them to send over an ambulance. I believe they didn't even have a con for an ambulance, so they couldn't even send the mother and child. They had to ask for an ambulance to come, and the baby passed away before the ambulance could arrive. I don't think Eric or anybody involved is willing to say that we know, the baby could have been saved. But here's the thing. They applied for a con after that experience, and they were still denied. They still said, no, you don't need, it doesn't look to us like you need a neonatal intensive care unit. And what's odd about that, by the way, is that there really wasn't many people opposing the con at that point, except for, I think it was essentially one complaint by the competitor. But otherwise, there were lots of people in the community saying, yeah, like a neonatal intensive care unit at Lewis Gale. That kind of story, I do think strategically, it resonates with people. It tells you what the real cost of this is. And so it would be nice if we could do a little bit more to shed light on that. My colleague, Elise Amez-Droz is doing some great work trying to pull up more and more of these types of cases. And this is where groups like PLF are so awesome, because they are very careful about selecting their clients, and every client is a sympathetic story and one that you can really try to highlight. So anyway, that's just another strategy I would recommend. And then another one I suppose I would say is I have not seen a ton of non-traditional ally interaction. It would be really good to work with Mothers Against Drunk Driving for the several dozen states that have cons for drug and substance abuse centers. How in the world in 2021 do we really think that we don't have enough drug and substance abuse centers? There are cons for psychiatric care facilities. There are cons for those who intermediate care facilities for those with intellectual disabilities. Particularly again, coming out, thinking in terms of where we are with a pandemic where mental health has been a significant problem in the country. I think there are potentially some untapped opportunities to reach out to those non-traditional allies and try to build the case for at least eliminating the cons that stand in the way for vulnerable populations obtaining care.
Great point, Matt. One of the things I want to go to, we have a lot of the researchers on here talking with us, but part of the great thing about this conference is the bridge between the practitioners and the researchers. So for the folks that are on the ground, and I see you, I'll call you out if I need to, who are prioritizing this issue, this session, what are the research gaps? What are the questions you can't answer? Let's talk about how do we bridge some of those gaps, and how do we bring the researchers together with the folks on the ground trying to do it?
Kathleen, I don't have a question, but I meant to jump in there, and I wonder if I could just follow up on one of Matt's points before we move on. I was just going to follow up on both of his points to say that, yeah, I do think that humans and judges, frankly, find stories compelling. And I'm sorry for everyone who's heard me say this, over and over. But one of the types of stories that is often left out when we talk about con laws is the stories of entrepreneurs. We very often hear about this narrative, it's consumers against big hospitals or something. But what about those people who are simply just trying to start a small business, providing something needed in their community, and they're deprived of economic opportunity? Those are really compelling stories that I think don't come to mind for a lot of people. And I just encourage, activists and others on the ground and in the legislature to consider bringing the really compelling entrepreneurial people who have been denied economic opportunity, and including those stories as well. And then the second thing I was going to follow up with Matt is I really liked what he said about Mothers Against Drunk Driving. I do think it's important we start thinking about creative allies. We found, for example, when we sued in Montana on behalf of a shuttle company, that it was really compelling in the legislature to have a sheriff there who testified about the lack of transportation and how treacherous the roads are in Montana. And because there weren't things at that time like Uber, and there were a lack of taxi companies and shuttle services due to the state's con law, that there was a very high incidence of drunk driving fatalities on those treacherous roads. And our client, of course, had owned a shuttle company in another state and was accident free and had a scot-free record in terms of driving. But anyhow, yeah, that's not something I think we typically think of when we think about allies. We think about, like-minded organizations or people who also want to see the laws overturned, but maybe not an independent third party who has some creative interest in the outcome. So, that really spoke to me. And I think we should all brainstorm moving forward, new allies, people who haven't been tapped yet, but may have an interest in overturning con.
Absolutely.
Kathleen, if I may, this is Garrett Ballinger here in West Virginia. Just a quick question regarding allies. Has anyone worked or reached out to the AARP? That seems to me a likely potential ally on something like this. Although I know the major national groups you'd never really know, but just a question for anyone out there.
Or even local chapters of AARPs.
Didn't somebody from Heritage go to AARP a couple of years ago? That's maybe running one of their initiatives.
Are you thinking of David John?
Perhaps, yeah.
He's on the research side of AARP. He's fantastic. He works, I think, a lot on the pension issues.
In Florida, the state director for AARP was incredibly supportive, and they had folks not necessarily testifying in support when the bills were up, but they would kind of waive their time in support so that lawmakers knew where they were standing on it. So that they were a good ally in that.
So Kathleen, to follow up, I posted a link to our Goldwater Institute investigative reporter, Mark Flattened, his investigative report on mental illness beds. And this is really, right now, this is going to be, I think, uniquely important because there is an intersection with criminal justice in the work that he's done. And so that's posted in the chat. In terms of following up on research, one of the emerging issues that really concerns me on this hospital issue is that there is a growing chorus of people talking about reforming hospitals so that you have tiered approaches to contagious pandemics. And we even saw a paper from Heritage on this issue proposing that you have hospitals that are specific for highly contagious, and this would of course be directed from the federal government. No doubt hospitals will want money for this certification and for these upgrades to the hospitals. But this is something that I think is going to be talked about a lot more in the coming 2 or 3 years, and will pose an additional obstacle to con reform, because there's going to be a strong interest in kind of delineating the hospital services, because as we saw during COVID, you had hospitals entirely shutting down, elective surgeries, going away for a while, and that's kind of reemerging in hotspots. So what sounds like a great idea is actually going to be a lot more federal spending, a lot more centralized control, and a lot more control over certifying how many beds are pandemic beds. What hospitals do they reside in? I mean, so we're going back to a lot of the same problems and issues that that we're seeing with con, only I think 10 times worse. So I think research in that area is going to be very important going forward. Understanding, what are there international models for this? What does it look like? What do we need to know? What do we need to avoid? How can you do it in a way that doesn't further centralize the power and cartel, strength of these hospitals?
Good point. Any of the researchers on want to talk? Is there anything on that already, or is something you're already thinking about? Any response to that? Oh, yeah, okay.
Something that we're thinking about, but just haven't studied yet. But I kind of want to even just respond to that from the point of I am an academic researcher. I'm not nearly as prolific with outreach as Matt, who's very special in the academic space in having these connections. But I do want to ask researchers like me. We sit in our offices, we've studied these policies, but we never really work with legislators or these different groups, even though a lot of our work could make a difference because it's showing you what the could be's could be, or it tests out different policies on numbers and figures out, okay, what might be the best avenue. How can we best connect with you all? Because that's something that I think is getting lost in translation. How can academic researchers like me give back to the community? That's kind of just a question for anybody who's willing to speak up to it.
I mean, I work at SBN and work with a lot of the state think tanks who are here. I think a lot of it is just doing things like kudos to PLF and Mercatus for putting this together. It's a lot of it's just bringing us all around the table and making those connections. Garrett in West Virginia knows who you are. He's seen your paper, can make those connections. Matt, you talked to a lot of these folks anyway, but I think a lot of it is getting people around the table and helping make those connections. Because I agree, I think sometimes we miss it too much because everybody's busy, everybody's kind of operating in their space when we don't realize that there's connectivity would accelerate all of our goals.
Well, and one thing we can do now that we're all connected is when I hear of a incidents where a legislator is proposing con reform. For example, in Oklahoma, they're proposing some pretty sweeping reforms. We will probably get an invitation to testify, and I would be happy to suggest that they invite you as well, Alicia. To be honest, I am looking forward to this legislative session because I'm going to be able to testify all over the country without leaving my office.
I would add, I think it's really important for academics, to the extent that they want to help change the world, to actually communicate with the public, right? So you write an article for a journal. What can you do with that information to educate the public? So maybe it's an op-ed, maybe you reach out to a policy organization to do a policy brief, co-author something with somebody, but making it so that that information actually gets into the hands of a wider audience.
Absolutely. Any other questions pop up? And I have a kind of a last word lightning round question for our panelists before we end our time together. All right, it's been a very fruitful conversation. Here's one I want to have each of the panelists address. As Matt said, it's going to be a very busy session. This is going to come up in a lot of sessions because it's so fresh. it's become just so glaringly obvious, and there is a lot of work to do to help to accelerate these efforts. So, question for all of you, last word, what is your call to action for this group? What is your if you remember one thing from all this, or you have one request, what is that? We'll go to Matt, Angela, then end on Alicia.
I'm sorry, would you say that again? If I have one request, what?
Yeah, so what is your call to action for people working on policy in the grounds, for people, maybe legislators, for how do we make ground at this, probably one of the biggest opportunities we have to make ground on con that we'll see in our lifetimes? What's your call to action?
Sorry, yeah. So I mean, one, of course, is see everybody on this call as a potential resource. We're all happy to come in and testify or do op-eds. But let's stay connected and let one another know when there's new opportunities. And sorry for the noise in the background. When there is, in almost every one of the 35 states, there's a legislator who is very skeptical of con, and they are really powerful allies.
Perfect. All right, let's go to Angela, then end on Alicia.
Yeah, as we're fighting to reform or remove con, I think it's really important that we don't underestimate the hospital associations and the hospitals, and really offensively try to find ways to weaken them. I think Saul provided a lot of good examples of how to do that. They did in Florida, and we should take those and other lessons to other states.
Perfect. And Alicia.
I think we really need to remember the value of the pandemic. It's been terrible and we've lost a lot of lives, but this has also been a natural experiment into a policy that had not been really stress tested before. I think this is a really great way to start with the groundwork of making the conversation for repealing. And if people are unwilling to repeal, at least building in the flexibility to be able to quickly shift, to quickly change, or to be able to have these rules either suspended during bad times or reformed in good times so that the bad times are not as bad. So remembering that it's not always the good times, and we need to prepare for that ahead of time by building in flexibility, or even outright repealing would be very, very important at this point.
Perfect. Well, a big thanks to all of our panelists for all your time, for all of you for all your time, because you really are part of this community that's fighting to help people have better access, lower costs to their healthcare, to create this different pathway. So a big thanks to all of you for joining. I'm going to turn it back over to Anastasia or Rachel to talk about next steps.
All right. Well, on that note, let's take a brief pause and meet back here at 11:15. That's Pacific time, 12 Eastern time. 2:30, sorry. We'll meet back at 11:30 or 2:30, wherever your time zone is. And let's pick up on that. And I'm really interested in this idea of information sharing. I really want to hear from everyone about their experiences trying to make change and succeeding in making change. Strategies for getting together, developing talking about where new research is needed or where are the gaps. What have you all experienced, and how can we push this across the finish line? So let's regroup in 15 minutes. You can either re-sign in using the same link, or feel free to just turn off your microphone and camera and take a little pause. And let's meet back here for a dynamic second panel.
It's a strong background choice, Sal.
Figured it was appropriate. I'll go off.
Okay, welcome back, everyone. Thanks for sticking with us. I know it's a long day, but we promise to make it worth your while because right now we are together going to develop the strategy to change the world. So thanks for coming back. And let's get started. I'm going to hand it off to my colleague, Molly Riddle, who works with me in Pacific Legal Foundation's Economic Liberty practice. And together, Molly and I launched a lawsuit this morning challenging a certificate of need law. So I'm sure we'll talk about that a little bit later. But with that, I'm handing it off to you, Molly.
Great, thanks so much, Anastasia. So hi, everybody. As Anastasia said, my name is Molly Williams. I am an attorney at Pacific Legal Foundation, and I work primarily in our economic liberty group, where I sue the government and challenge anti-competitive laws like certificate of need laws. So also welcome to part 2 of today's policy summit. We will be discussing where do we go from here. So the first panel was intended to establish the state of con laws as they are now, and then now we want to look at the strategies and tactics for dismantling those laws. And we touched on this a little bit in the first panel, but I hope we can just continue that conversation here, introducing a few new panelists. So we will hear from some of the leading experts in the con reform space. We will hear from Dr. Matt Mitchell, who you saw in the first panel. He is a senior research fellow and director of the Equal Liberty Initiative at the Mercatus Center at George Mason University. He is also an adjunct professor there. And at Mercatus, he has led their research and education effort on certificate of need laws. His work has led to, contributed to dozens of debates in states across the country. And I know as a litigator who challenges con laws, I visit Mercatus's website routinely, if not daily, when I have whatever question it is about a con law in a particular state or looking for a site for some research. So their work there is tremendously helpful to us in our litigation effort. We also have with us my colleague, Anastasia Bowden. She is a senior attorney at the Pacific Legal Foundation. She leads our economic liberty group. She represents entrepreneurs in lawsuits that challenge anti-competitive licensing laws. A big part of her litigation experience has been devoted to challenging con laws. Initially, she brought these lawsuits in the transportation industry and has since expanded to challenging those in the medical context. So one of the smartest moves I made when I became a litigator a few years ago was I made Anastasia my mentor. So I have the privilege of being co-counsel with her on a number of cases. As she mentioned, we filed a lawsuit this morning. So lots of exciting things underway. We'll hear from her about that later. Then we have Megan Forbes from the Institute for Justice. There, she serves as legislative counsel and advocates for legislative reform across the country in areas of economic liberty, free speech, property rights, and other civil liberties. Before turning to legislative work, Megan litigated and successfully challenged licensing requirements for hair braiding in Iowa and taxi license caps in Ohio and Wisconsin. Recently, she worked to see legislative con reform take place in Nebraska and the transportation industry. So we'll look forward to hearing about that effort today. And finally, we have Maura Tenenbaum with us. So Maura has been a nurse for 22 years and a nurse midwife for 11 of those years. She discovered her love for legislative and policy work in 2016 while working to pass legislation that gave registered nurses full practice authority. A few years ago, the hospital where she worked in West Virginia closed. So after losing her job, she and one of her midwife colleagues set out to open their own practice. However, they discovered that laws there prevented her from doing so. And so she devoted her spare time to seeing a change in that law. And after that legislation was passed, while she's moved away from the state, she's seen many of her former midwife colleagues open their own practices there. So we'll hear about her activism efforts and how she spurred change in her state. So many of you attending today, y'all have experience in the con reform space, or you're at least aware of them. And each of the speakers that we're going to hear from, they're intended to reflect how moving the needle and how seeing a change in the law requires a strategic approach. It requires a tactical one as well. You kind of have to be firing on all cylinders to make that very difficult task possible. And so we have Matt reflecting the research component of it, Anastasia representing the litigation, Megan, legislative reform, and Maura, the activism and the community engagement. So hopefully we can uncover how these can all work together to create that positive change. And as we said in the first panel, we'd really like for this to be an open discussion. So audience members, please feel free to chime in with any questions or comments. We're all hoping to learn from each other. And as Anastasia said, figure out a way to change the world. So let's do it. Let's use that chat box. Feel free to unmute yourself. And with that, I'm going to kick things off with asking each panelist for their kind of opening thought on one question. And that question is, what is the biggest obstacle to con reform in their work? And I am going to start with Anastasia.
Lucky me. Well, I suspect that, each person's answer is going to reflect the particular strategy they employ. So, Megan working in with legislatures for legislative reform, she probably encounters something slightly different than what I encounter in the courts. And I think in the courts, the biggest obstacle, there's probably three. And the first one actually isn't related to con specifically. It's a broader problem we have, and that is that courts have become overly deferential to the legislature. And that is due to years of cajoling the courts and telling them that they should not be activists, that they should not replace their own opinions with the legislature's opinions. Now, of course, I would agree with that. Courts should not replace, duly passed laws with their own opinions, but it is the role of the courts to strike down laws when those laws violate the Constitution. And it is their duty to meaningfully engage in, with legislation to ensure that it comports with the Constitution and does not violate our rights. So that's something we have to sort of combat against, is just, decades long. There's been a decades-long ideological movement to convince courts not to meddle. Well, actually, courts should not only feel free to strike down laws when necessary, they should be skeptical of legislatures, because legislatures are subject to capture. And when they do, particularly by strong groups that have an incentive and the ability to sort of trot over the minorities' rights, whether that be racial or economic minorities or whatever group doesn't have political power at the moment, it's the duty of the courts to be a refuge for those people and to fight back against that sort of capture. So that's something that we really have to face. A second hurdle to success in the courts is the fact that courts don't seem to care about economic liberty anymore. They just don't treat it in the same way that they treat the precious right of let's say, First Amendment free speech. And that's not, of course, free speech is a precious right, but so is the right to earn a living. And I think we have some major rehauling to do when it comes to rehabilitating that right and sort of combating this idea out there that work is just something menial. It's something that we have to do. It's something that, it doesn't play a central importance in our life or our existence and our identities, when in fact work is very central to people's identities. it doesn't have to be something ideological to still be meaningful to people. And so I think that's something, this is a cultural and ideological thing that we have to do. The last thing that I think stands as an obstacle, and this probably applies across the board to all of us, this is something that we've touched on today, and it occurred to me multiple times when I was preparing for this panel, is that there truly is a lack of coordination among all of these wonderful allies. It's kind of shocking to me that it never occurred to me to call up a researcher and say, can you direct me to the best research on this, or to maybe offer ideas about where I've found research is missing that would aid in our litigation, or even between different groups litigating. Sometimes I see a lawsuit pop up and I think that's really interesting. Well, why don't we just call each other and talk about that and sort of brainstorm together? There's a real lack of coordination, and I don't think that we're trading on each other's strengths. And I think that we could improve in that way. Not everyone has the capacity to do all things. I don't have the capacity to mobilize a bunch of people on the ground and to get some grassroots things going. That's not something that we're good at. I know IJ has a better capacity for that. And if we were all working together, I think we would be stronger. And so I think that's been an obstacle when it comes to reform.
Great. Yeah, I think even there seems to be coordination as a theme today. And I know being a litigator, we can be like locked in our offices sometimes and feel like you're the only person in the world fighting this. So like not only for the sake of being successful in our efforts, but for the rallying, effect that can have of reaching out to other people that are also squirreled away in their office, working for the same goal can be really helpful. So from there, Megan, I'm going to have you share your thoughts.
Sure, and thank you for having me today. It's great to be here with all of you. For me, I would say the biggest obstacle that we're facing when it comes to our legislative effort is that we're going up against these entrenched interests. They're very powerful. They contribute regularly to political candidates, and we're not contributing. We're in a different position. We're there sharing research and fighting for what we think is right. Unfortunately, with COVID, what I've seen and what I've been a bit surprised about is that these interests, especially hospital associations, have become more entrenched because they're being perceived as part of a COVID response. They're spending more time with governors' offices, they're spending more time with policymakers, and they're in a difficult place right now, which we touched on in the previous panel. So there's this idea too among legislators that we don't want to kick hospitals while they're down, and we should be doing everything we can to try to help them and help with the COVID response. So that's created another thing that we're having to work through right now. But I think all of these things, though it makes the climate a bit more difficult to push for reform, means we should be trying even harder to accomplish reform and to raise the profile of this issue to try to change the law.
Yeah, that's been really eye-opening today, is hearing from people on the ground saying there's not an appetite for change, which makes sense. Like I should have thought about it. I haven't been, exposed to it in that capacity. So it's definitely something we have to strategize about and think about how to overcome it. So Maura, could you share with us your thoughts on this?
Yes. So, my thoughts are that I am the Vice President for Government Affairs and membership of American Association of Birth Centers, and we're a trade organization, membership organization for freestanding birth centers, also for hospitals that have an actual birth center, a separate facility from labor and delivery located inside and operating on the birth center model. And those are called alongside midwifery units, or AMUs. But most of our membership is freestanding birth centers. And we put out a position paper that I linked to earlier in 2016, talking about how the certificate of need was an obstacle to birth centers. And so my part has been, representing our membership, not being out in the trenches working legislatively against birth centers or against certificate of need yet, but that may be something I add to. My personal legislative focus has been laws for midwives, laws for birth centers, laws for nurses. But from that standpoint, I want to mention that during the pandemic, a birth center in New York City, in New York City, was able to open in just 3 months. And New York is infamous for a large amount of regulatory paperwork, et cetera. So a previous birth center opening in New York, where there are only 3 birth centers total, a previous birth center in Buffalo took 3 years to open, largely getting through the certificate of need process. So it was amazing to me that when the bureaucracy cooperated, quick results could happen. West Virginia, where I'm also active as a nurse and midwife and go help my friends in their practices sometimes, the legislature is looking to look at the certificate of need program this year, this legislative session, which starts in January. So I'm very eager to throw my efforts into that. And a colleague and I just wrote an article for our publication, West Virginia Nurse, talking about how certificate of need is a barrier to birth centers. So especially as more and more research comes out highlighting the safety of the birth center model, we're more eager to get barriers removed. And I want to say that earlier somebody had mentioned about how the perception is that only super healthy women can have a birth center birth. And really way over 50% of women would qualify for a birth center birth. And exciting new research has just come out highlighting that even obese and very overweight women are safe to have a birth center birth. We've been waiting for the data for many years, and now we have convincing data that these women also, which represent a majority of the American population, should be able to have birth center birth. So in this time of women wanting to avoid the hospital because of the pandemic and more research highlighting the safety of the model, it's absolutely nonsensical to put these ridiculous barriers in place. Lastly, I want to say that a group, Primary Maternity Care, is currently proposing model birth center regulations that would work, for states that want to implement birth center regulations. This would be a go-to. And one of the very first items in the model regs is certificate of need, if it exists in the state, will not apply to birth centers.
That's great. Well, it sounds like there's a lot of momentum in the birth center space. So that's great to hear. And then Matt, I'm going to turn it over to you.
Sure. So I probably don't have much more to add than what's already been said, except that what I might do is frame it in the terms that economists think of it as, this is a classic story of concentrated benefits and diffuse costs. So, the benefits of the policy there are some, which is higher profits for the protected hospitals. It's concentrated on a few organizations, and the costs are diffused across millions of consumers, patients, and a few hundred would-be competitors who are just kind of getting started. And so as it turns out, it's very hard to get politically organized. There's a lot of upfront cost to that. And so if you are small in number as a interest group, it's much easier to get organized, and it's much easier to understand the laws and understand the regulations, to form relationships with policymakers. Whereas if you're a patient, most patients don't even know that these things exist, of course. And if you're a startup, a newcomer, you may not know how they work. You may not have the relationships. And also, even if you do understand the way it works, it's hard to put your neck out. If you're a small ambulatory surgery center, many of them are really, frankly, just scared to raise too much of a ruckus. So that dynamic of concentrated benefits and diffuse costs, it plays out over and over again. And what does it look like? Well, it looks like, me going down to Florida a few years ago and testifying against the con law with one or two other people on my side, James Madison Institute scholars among them, and then 30 or 40 hospital executives lining up on the other side of the issue. And so that's a very, very difficult dynamic to overcome. But that's what it is. And I'm interested in, at some point, in talking a little bit about the benefits, perhaps the different costs and benefits of going the policy change route versus the legal change route, because I think that dynamic of concentrated benefits and diffuse costs, it's a little different in those different arenas.
Yeah, that's really interesting. Well, it sounds like we are all in the David and Goliath dynamic in our capacities in trying to see reform. So it can feel that way in litigation as well. But the image of being up against those people testifying makes me scared. So I understand that. All right. Well, I think that I want to start off, Matt, as you just said, talking about how it can be different in different arenas, talking about it from the litigation perspective. So talking with Anastasia, I mentioned that you have extensive experience challenging con laws in the transportation industry. So if you could share with us about your experience challenging West Virginia's con requirement for household goods movers.
Sure. Yeah, as you said, we've challenged con laws in many states in the transportation industry. And I'm sorry for those that, I just spoke with Matt and Sal and Garrett on a panel about West Virginia, our efforts in West Virginia. So I'm sorry to repeat myself to anyone here. But the reason I'd like to speak in particular about this case today is because I think there's a lot of lessons to be learned that we can all talk about in terms of strategy. So in West Virginia, we were suing on behalf of a man named Artie Vogt. Artie Vogt started out of college driving for this moving company. Eventually, he worked his way up. He saved up enough money over the years and was eventually able to purchase the company along with his wife. And he didn't know that when he purchased the company, the certificate of need for his moving company did not transfer with the purchase. He just didn't know that. And so he was just continuing operating as things had been, as it had been for 20 years when he was with the company. And in fact, the company had been open for 100 years prior to that. So they were just business as usual. And one day they get a knock on their door with the regulators telling them that they don't have a certificate of need. And so, many people don't even know these laws are on the books. And even when they hear about them, they assume, okay, well, how hard can it be? Of course I'm needed. For Artie, he was already operating. So, he had a successful business. The company had been open for 100 years. Of course, no problem showing that he's needed. So he goes and he applies for a certificate of need. And over a year later and $10,000, he's denied. They said that his business is not in fact needed. And this came as quite a shock to him. So we represented him. And what we found in West Virginia was, as in many other states, this law operated as a competitor's veto. No new company had been granted a certificate of need in over a decade. And in particular, there was a really interesting thing going on where it was creating an in-state cartel where there was particular discrimination against out-of-state businesses like Artie's. Artie actually was located in Virginia on the West Virginia border. Where no new company from out of state had been granted a certificate of need in over 20 years. And so we sued. And the interesting thing about this lawsuit is we were fully briefed. We thought it was going really well. We thought we had a very strong case. And as we're waiting for the decision, the legislature repealed the law. That's great. That is a win for our client. It's a win for West Virginia. People in West Virginia are freer than they were before the lawsuit, before the change. It can also be extremely frustrating that you have to invest so much time and resources and sue to get that kind of change. And it can be frustrating because, we're there to set precedent and to make sure that the government can never do this again in the future and can't do this in other industries as well, that it can't take away people's economic liberty for the sole purpose of protecting others from competition. That's a really important precedent for us to set. And when our case gets mooted, we no longer have the opportunity to set that precedent. So it's a blessing and a curse. And at the time it was frustrating, even though we were happy. Artie was happy. He wanted to win the lawsuit too, of course. But it occurs to me now that we've started moving into the medical space with certificate of need and seeing how difficult it is to win cases in the medical space compared to transportation, where we had a little bit of an easier time. In reality, that was sort of a blessing. That was a lucky thing to have, that the legislature just caved to us. And that happened pretty much towards the end when we started suing in the transportation industry. Legislatures started rolling over. We had legislative change in Oregon, Missouri, West Virginia, Montana, Pennsylvania. So it became pretty routine and we were always frustrated. And now looking back, it seems to me, wow, how lucky were we? Because now with this medical fight, we're going up against extremely hostile, entrenched, and powerful medical interests that are not letting that legislative reform take place. So that's just an interesting thing in terms of strategy, to think about. Maybe you're lucky to get legislative change and litigators should reconsider seeing that as a bad thing. The second thing I want to point out about that case is, sadly, we have been trying to get in touch with Artie for some time, and we were having trouble, and I Googled him recently, and it turned out that he passed away recently. And you know, I was sad. I really enjoyed Artie as a human. He's such a strong person. It takes a lot of gall to stand up in a lawsuit like that. Not everyone is willing to do it. He was very kind and happy, and you know, he started that fight because his wife had recently passed away and she had really wanted a certificate of need for the company and she felt unsuccessful. And when he was able to get legislative reform, he named the law after his wife. He called it Stephanie's Law, and he was very proud. And we have a video of him talking about it right when he finds out about the legislative reform, and he's in tears, and I get tears every single time I watch that video. So, you know, I was sad. And what I thought was really interesting is when I read his obituary, it's very short, and, you know, his family wrote it, of course. And the central part of it is that lawsuit. It's the fact that he was so proud that he was able to bring that lawsuit and effectuate change and do it in his wife's memory. And I think that kind of hammers on a point we were talking about earlier about the right to earn a living, and bringing to bear these entrepreneurs' story in addition to consumers and you know, all the other interested parties. These things mean a lot to people. I'm sure Moira can speak to this too. This is not simply a regulation where it's like, okay, well, you can't do this, but go on and do something else now. Move along, you know, find something new to do, or just adjust, or go work for another business that has a certificate of need. No, this is people's livelihoods. This was a moving company. You know, maybe people would say that, well, it's not his passion. No, it was his passion. He spent his life, you know, earning and saving up to purchase that company. And so I think, you know, the fact that it took up a central part of his obituary really made me proud. And I think to do what I do. And I think it also just, again, emphasizes the point that we should really tell these people's stories, not only to do them justice, but to rehabilitate the primacy of the right to earn a living in our country.
Yeah, I think Artie's story is there's so many lessons to take away from it. It like talks about how litigation and legislative change can work hand in hand sometimes, and also the importance of a good, compelling story goes a really long way. And so in that, you talked about how you've since moved your litigation focus into challenging cons in the medical field. So what prompted you to make that change or transition?
Yeah, well, I think we've always wanted to sue in the medical field, but it's a little bit harder of a case. I mean, it shouldn't be, and theoretically, it's the same story. We know what's happening here. It's a competitor's veto, and these laws do not effectuate their goals. They simply exist as a handout to the existing businesses at the expense of everyone else. So it's the same narrative, and yet what we find is that courts are even more hesitant in the realm of medicine to strike down laws because they think, you know, first of all, they have the government telling them people will die if you strike down this law. So then they get, you know, uptight about it. And also, I think sometimes judges maybe feel like it's complicated policy, it's medicine. Who am I to sort of, you know, second guess the legislature and have to think these complicated economic or scientific things through? When again, in reality, we think the calculus is pretty straightforward. It's just, are these laws effectuating their goals? No, they're not. It's unconstitutional economic protectionism. But in any event, you know, we had wanted to move into medicine, but transportation was just an easier sell to people. I think it's really easy to tell people that these laws have no place when it comes to a moving company, that all it should take if you want to open a moving company is purchasing a truck and slapping your name on the side of it. And so it was a good place to start. And in fact, you know, after we won a lawsuit in Kentucky, as Angela talked about earlier on behalf of Raleigh Bruner, who's sort of the central figure in the report that was released today, we thought that was good precedent now to go back and start expanding that precedent to medicine. And what we did in Kentucky was sort of unique, where we use that transportation precedent as a bridge to medicine, because we brought a lawsuit on behalf of an ambulance company. And so that sort of gets the best of both worlds. It's medicine, but it's not overly complicated. You know, the company there, it's an ambulance company, but it's really just emergency medical transport. That is, it's not, you don't pick up 911 and they wouldn't call our client. It's more like if you need you need to go to a doctor's appointment from a nursing home, or you know, if somebody needs a quick trip to urgent care, but it's not emergency ambulance services. So it allows us to capitalize on the precedent in the transportation realm and people's sort of straightforward understanding of transportation and move into medicine. And so that was a pretty strategic decision in Kentucky. And now, of course, today in Louisiana, we're taking it one step further and getting away from transportation altogether. So it's a, you know, it's not random. It's very strategic and took a lot of thought, and that was sort of our thought behind it.
Yeah, well, speaking of the lawsuit in Louisiana, I would love to hear about it. So I noticed that it's a facility need review, which maybe you can explain a little what that is, and is that just another name for con, or yeah, we'd love to hear about it.
Sure. So this morning, as you know, as my co-counsel, we sued on behalf of Ursula Newell Davis. Ursula is a very experienced social worker. She's a mother to a special needs child, and she's an entrepreneur. And she started a company to provide what's called respite services to children in Louisiana. Respite services basically give parents of special needs children you know, some time off for themselves. It can be very demanding to be a caregiver to a special needs child. I know this. I have a brother who's special needs. And so this case, you know, really resonates with me. And it also provides care to children who need it. And in particular in Louisiana, where these children are sometimes, frankly, just left alone because their parents don't have a lot of resources and they work odd hours of the night. And so the result is that these children just wind up with no care at all. And so Ursula is a social worker, and having seen this, she wanted to step in and provide that care. So she started a company, and she applied for facility need review, which is basically a certificate of need law with another name. The only difference is that certificate of need laws usually have a protest procedure where the existing businesses can actually protest and intervene in the process. And here, the existing businesses don't have that prerogative, but it's otherwise the same. The government is just looking at how many existing businesses there are and then determining if you're needed or not. So, you know, for all intents and purposes, it's the same sort of law as a certificate of need law. And Ursula applied in a 2-page form letter with absolutely zero explanation unique to her case. She was denied. And essentially we represent her now, and she's a firecracker. I mean, I every time we speak to her, I'm either in tears or I'm saying Ursula for precedent. You know, all she wants to do is provide care to kids who could really use it. And there's no reason the government should be telling her that she's not needed. I think the parents should be able to choose and decide whether her business is needed. I don't know if I'm missing anything, but if I am, Molly, you can be the one to say it because you know her case, you know, better than anyone.
Yeah, I think you definitely hit all of the high points. I would say that in thinking about the obstacles that we run into in litigation in con, we're hoping that with this case, those justifications aren't going to stand up against it. So like the cream skimming, which the idea that, you know, hospitals have to maintain their monopoly to cover their expenses. They need the more lucrative services as well to cover the less lucrative services that they perform. And here with respite, we hope we won't run into that problem. So we're optimistic there. My final question for you, Anastasia, is where do you think the future of con litigation is? Do you think it's in state claims, the federal constitution? And maybe I guess also our Louisiana case, we bring both federal and state claims. So that's another strategic point about it.
Yeah, well, something that's interesting is I think people don't even realize that certificate of need exists in more place than they may assume. So some people don't even know about transportation. Others don't know about apprenticeship programs in California or schools in some states. And so there's a lot of other targets for certificate of need that we can go after. But more generally, where's the future of certificate of need? I mean, there's a lot in the hopper right now. You know, we have a few lawsuits. IJ has quite a few lawsuits. We just saw a lawsuit out of Mississippi from, I think it's the Mississippi Policy Center. I hope I'm getting that right. And so there's a lot going on with certificate of need. And I think we need a while for it to sort of shake out and see what happens. But after that, it's probably time to sit down and reassess, probably in the same way that, you know, the movement for economic liberty needs to sit down and reassess, because it's very difficult, and we need to decide whether things are working. I think all of us who litigate in this space suffer a lot of losses due to the court's unwillingness to really engage, as I talked about earlier. And so it's worth thinking about new causes of action. It's worth thinking about different venues. It's worth thinking about different strategies. It's worth, thinking about different types of clients. I think everything is open for reassessment. And so I don't want to, I'm more interested, rather than telling everyone else what I think the future is, I'm more interested, after the other panelists speak, opening that up for discussion and hearing from other people about what the future may hold.
As a new litigator, the dynamic between Anastasia and I often is, I have so much confidence in the 14th Amendment in our federal constitution. And she's like, I've been through this a lot. So excited to see what we come up with in our later conversations. I am now going to turn to Megan and hear a little bit about her legislative work. So as I mentioned, you recently saw con reform in Nebraska's transportation industry. So if you could tell us what that reform did it go far enough? That would be great.
Sure. So in Nebraska, we worked with the Platt Institute there, an SPN in Nebraska, to repeal Nebraska's con law for household goods movers. Originally, we sought a broader reform, and we were pushing for a broader reform. We wanted to repeal the con for taxis, household goods movers, and non-emergency medical transport. The bill that ended up passing actually included household goods movers, carriers of railroad employees, which was kind of an unusual thing to us, but was added in throughout the process, and agritourism transportation. We were really happy about this reform, but of course we wish it would have gone further, and it speaks to just how powerful these interests can be, even still in transportation. In Nebraska, we were working with an entrepreneur who we're now representing in litigation, who wanted to offer non-emergency medical transportation services as part of a home healthcare company that he had started. He had an amazing story. He came to the United States from Togo with $60 in his pocket, and he had overcome a lot of obstacles in his life. And then when he opened up this company, it was very successful, providing home healthcare services. Then he realized his clients needed transportation to and from medical appointments, in addition to and from different errands. And under Nebraska's law, he could actually take them to Walmart, but not the Walmart pharmacy, because that's how the con law operated. Because if he took them to the pharmacy, that would be considered non-emergency medical transportation. So to make a long story short, he was critical in our advocacy and sharing his story. He drove 2 hours in the middle of the Nebraska winter to come testify in support of the bill. And he had been through this process of trying to get a con. The Nebraska Public Service Commission found he was fit, willing, and able, but denied the con because of his opponents. And at the committee hearing, there was a parade of opponents who came and testified against the bill. He testified in support of the bill, as did IJ and Platt. And what was really interesting to me was that he told me most of the opponents who had come to testify against the bill were the same people who were at his hearing on his con. So he felt like it was a very organized effort to keep him out, and was just disappointing. Regardless, though, I think his story really made a difference. Unfortunately, we weren't able to get the reform done for him. It was like his stories moved legislators to want to act, and we were able to repeal cons for household goods movers. But when it came to repealing the con for non-emergency medical transportation, the taxi industry was just too strong, and all of the lobbyists associated with them to keep that reform from going through. So IJ's now representing him in court in Nebraska and litigating this case, and we're hopeful he'll soon be able to offer these much needed services to his clients moving forward.
That's really interesting. Thinking about going at it from the legislative angle before moving to litigation, I guess, what influenced that decision of deciding to try to get reform before initiating the legislation, or sorry, before initiating the litigation?
So this is a little different from how we operate a lot of times at IJ. I was working on this bill before we even met Mark, and I was reviewing public records, looking into different instances of denials of cons and calling people who had been through the process. And Mark was one of those people who reached out, and he was interested. You know, we talked with his attorney, and he was really interested in supporting this. And that's how we learned about his story. And then it was really a compelling story. He has this great service that he wants to offer, and there are people who need his service. So we started with legislation as opposed to litigation, because I was already involved in the legislation, and we didn't know if the bill was going to pass. We were hopeful it would, and it would have resolved the case. But as I mentioned, we couldn't overcome some of the special interests there. So then we thought it was a perfect candidate for turning to litigation.
Yeah, that's great. What would you say one takeaway is from that experience of influencing how you'll approach con reform in the future?
I think an important takeaway is that stories matter, grassroots matters in this space. We can talk about research all day. The research is incredibly important, and we need that. But for legislators to move them and to make them feel compelled to act, we need somebody who is available to share his or her story, and multiple people, really. We need different angles to approach reform. With the reform in Nebraska, interestingly enough, BNSF was the reason why railroad employees or carriers of railroad employees were excluded, and they became involved in sharing their issues they had been having with transporting employees. So there are these interesting different sides of the policy that I think are important to share and highlight when you're working on these reforms, and that can help make legislators act.
Definitely. You know, in the conversations we've had, even in this panel, I've thought, I'm like, there's so much research in the medical context of con. I don't know if there's as much. I mean, I guess PLF, we just issued our transportation report, but even despite having so much research, you know, we so often see we have to have something more than that. So I think that's a really good point. And I wanted to touch a little bit on your litigation experience. I read about your case in Iowa where you represented hair braiders who challenged licensing laws, and that ended with a legislative victory. I believe the same was the case in Ohio, where you challenged the cap on taxi permits. So while that isn't directly related to con, I think it speaks to how litigation and legislative reform kind of go hand in hand. So for those cases, could you share how it ended in legislative reform?
Sure. So the cases were a bit different. In Iowa, we had been litigating the case for quite some time. Iowa had one of the most burdensome licenses for hair braiders in the country. The Cosmetology Board was actively defending against the lawsuit. It did not seem like they were going to try to moot the case. And then we finished with discovery, and we felt pretty confident about the case. And at that point, we learned that the board was quietly pushing a bill at the state legislature that would have still had some requirements for training for braiders. So it wouldn't have been the full reform that we were seeking with our litigation. So we had to kind of take off our litigation hat and put on our lobbying hat and start working to make sure that we were still able to accomplish that reform. As Anastasia mentioned earlier, it is disappointing when you're litigating these public interest cases to not get a court decision, because you know a court decision sometimes can have a broad impact when it comes to being able to create a precedent that you can apply to other people. But in this case, our clients and the braiders in Iowa were incredibly happy with the result, and we were still able to accomplish that reform. Sometimes I think that litigation really can help lead to legislative change, because it gives legislators a reason to act. They see the issue as problematic. But I've also seen litigation used as an excuse not to act in some states. So I think it really depends on whether the legislator is motivated. If the legislator is interested in the issue, litigation gives them another reason to push something forward and gives them, that reason to say, we need to do this right now. But if a legislator doesn't want to do something, he or she will be very quick to say, oh, let's let the courts decide here. There's no reason for us to address this. This is something that the courts need to decide. So I think it can be helpful, but sometimes it really doesn't make a difference too.
Makes sense. My final question will be, what differences do you see in pushing for legislative reform in the transportation versus the medical industry?
I think with transportation, legislators have been a little bit more willing to talk about reform than I've experienced so far with the medical industry. And I think too, there's obviously differences with what's going on in the world right now with COVID, but in the transportation industry, we also have Uber and Lyft that we can point to that has been very helpful in showing how silly cons are, and that there are these providers that have disrupted the whole regulatory model. And in the medical industry right now, we are still working to show how cons are not working. We have all this research and we're putting that out there, but you still have to face arguments about life or death and the provision of charity care and just some differences that I think make it a little bit more difficult to push on the legislative front. So they're both uphill battles and both involve special interests that you have to overcome. But I do think medical is slightly more difficult.
Yeah, that makes sense. Well, hopefully we can hear from Maura from her success of kind of activism and how that can aid that process. So thanks so much. Matt, I'm going to turn to you now and ask a few questions.
Molly, I think you just muted yourself accidentally.
I did mute myself. Thank you. Given your knowledge of how detrimental con laws can be, I imagine you weren't surprised to see the rapid suspension of con laws across the country, or were you surprised?
I wasn't terribly surprised in the sense that, I believe Rahm Emanuel and Milton Friedman were both right when they said that a crisis is a time for change. I actually think both Rahm Emanuel and Milton Friedman have been quoted out of context here. I don't think either of them were rooting for crises. But specifically what Milton Friedman said is during a time of crisis, whether real or imagined, that's when you see change, and policymakers will turn to ideas and, in his words, whatever ideas are lying around. And so I think one of the things that was nice here is we and SPN groups and IJ and PLF and all of us have been making sure that legislators in pretty much every one of the 35 con states had these ideas lying around. They knew that con limits supply, so they were able to quickly pull on those ideas and use that as a way to try to expand the supply of healthcare. I'm always surprised when special interests are defeated by general interests, but I also know if you look at the course of the 20th century that it really does happen. This isn't an isolated incident. It's not entirely unheard of for economic freedom to win. So I was pleasantly surprised, but not flabbergasted.
That makes sense. Well, seeing that so many of the laws were suspended, do you see an opportunity for research looking at how healthcare is transformed during the period of suspension? So we talked about this a little bit. I know there is work being done that we mentioned in the first panel, but if there's anything that you would add on that, I would imagine it'd be like a great opportunity to gather evidence and see, and maybe it's something that we have to wait for a little while before we'll be able to.
Yeah, I do, and I commend Alicia and her co-authors for the work that they've already done in this space. I will point out it's a little bit tricky from just from a scientific perspective. So the best analogy I can give is with the way that we do controlled trials of a new drug. So ideally, what we would do is we'd convince 25 states and only 25 states to reform con, and then we'd tell the other 25 keep it because we need to have this controlled experiment, and ideally they would be randomized, and the ones that keep it would not be systematically all that different from the ones that don't. But of course, we don't do that. And part of the reason we don't do that is because we also believe that con is standing in the way of progress. And so we want all 50 states that have con, or that's actually 35 that have it, to get rid of it. Sometimes our science, what we want as scientists is not always compatible with what would be ideal, obviously from a policy perspective. So it's going to be a little bit messy. So we're not going to see as clean a results coming out of this as would happen if it were a nice randomized controlled trial.
I always have to remember that the 20 plus states that don't have con laws, the sky hasn't fallen there. So that's always
Right.
good evidence
Right.
as well. So in terms of your con search, I mean, you've led the effort at Mercatus for many years now. What inspires your focus? What becomes the targets of your ideas and things? Is it legislatures that are calling on you, or litigation, or what's that like?
Well, what really brought us into this topic in the first place, I did not begin as a healthcare expert by any means. My dad's a doctor, but that's about, was the extent of my knowledge. What really had attracted me to the issue was the inequity of it. I was interested in public policies that favor particular groups, firms, industries, occupations. So I'm also interested in, target economic development subsidies and occupational licensure and things like that. And this was, what struck me is that this was just such a blatant example of people using the power of the state to limit competition. And you see this, by the way, just if you look at the guidance that con regulators use, in many states, they can turn away a con application simply if it can be shown that it will duplicate services. Well, what they call duplicating services, normal consumers and economists call competition. The duplication of a service is the way that you get people to lower costs and raise quality and tailor products and services to the dynamic and ever-changing needs of consumers. So, and the fact, that in many states, would-be competitors sit on the con boards, and even when they don't, they're able to come before the con board and plead their case. It kind of disgusted me from that perspective. That's really what led us to it. And once we started digging into it, we built our research entirely around the claims of con advocates. So I think I mentioned this on the first panel, but I'll go into a little bit more detail here. They claim that con is needed to ensure, quote, an adequate supply of care. Well, off the bat, why would restricting supply increase supply? It doesn't make sense. And sure enough, when you compare the experiences in the 15 states that don't have con laws with those in the 35 that do, you find, I'll rattle through the stats, con laws are associated with 30% fewer hospitals, 30% fewer rural hospitals, 14% fewer ambulatory surgery centers, 14% fewer rural ambulatory surgery centers, 100%, there are 100 fewer hospital beds per 100,000 patients. There are fewer dialysis clinics, hospice care facilities. People have to travel longer distances to obtain care. They're more likely to leave their county or their state in search of care in con laws relative to non-con laws. So states. So it's very clear in terms of access, in terms of cost. There is both higher spending on a per patient or per citizen basis, as well as on a per unit basis. So procedures actually cost more in con states relative to non-con states. And then finally on quality, there's higher incidences of mortality following heart attack, heart failure, and pneumonia, greater incidence of having to go back into the hospital following a heart attack and a heart failure. There's higher mortality due to complications. There is even lower patient satisfaction levels in con states relative to non-con states. So all of our research has been built around the claims of con advocates. Where I think there's probably room for us to be a little bit more, go on the offensive, is to make our own claims, or investigate our own claims. So we've done this a little bit. I think it's been mentioned already, but Thomas Stratman has a study looking at the relationship between PAC contributions and the likelihood that you'll get your con approved. And lo and behold, if you make more PAC contributions, you're more likely to get it approved than if you don't. And if so, I think that's one instance where we could, that's not really just reacting to the claims of con advocates, but there are others. I would like to do research, maybe Alicia and I can talk about this, but and collaborate. I'd love to do research on the relationship between con and access to care for vulnerable populations. What are we seeing, particularly during the last 10 months, or in terms of deaths of despair, in terms of addiction, in terms of access to psychiatric care and drug and substance abuse care in con states relative to non-con states. I think that's an area that's ripe for reform, and it would allow us to go a little bit more on the offensive in terms of asking questions, out of that are important rather than just reacting to the claims of con advocates.
Yeah, that makes sense. I wanted to ask as a last question, one that was raised earlier. I wanted to discuss it more about the research that shows the opposite of what all the research we've talked about, like that saying that con laws are effective at decreasing cost and increasing access and quality. What do you think is the best way to respond to that?
So there is, to my knowledge, no research showing that con increases access. That's probably, of the three, legs of this stool: access, quality, and cost. That is by far the strongest evidence con decreases access to care. On quality, my take on it is some of the earlier research was a bit mixed, and it tended to show some increases in quality on very relatively narrow cases. So I think there was some research showing coronary bypass surgery. And I would note it's theoretically possible. The basic idea here, the theoretical story that people tell is, okay, if you have fewer providers, those providers are going to end up having greater volume and seeing more procedures will be channeled through them, and they will get better at those particular procedures. That's theoretically possible, even if you can also grant that there's this other strong theory over here, which says that competition tends to increase quality. And so you have to turn to the data. My take is that the studies that use broader and multiple measures of quality. So again, that the Thomas Stratman and David Willey study has that characteristic. The studies that use newer data, that has that characteristic, as well as Alicia's study, as well as studies looking at all-cause mortality. And I put in the chat room the study looking at nursing home quality. All of these are use the most recent quality. And then I also think identification is really important. So this sounds a little technical, but the basic idea here is we're not positive that the states that get rid of con are random. So they may get rid of con because of certain differences in quality. So one of the best ways to try to cut through that and to make sure that we're actually seeing the effect is to look, for example, at communities that straddle a con and a non-con state, because all sorts of unobservable factors are going to tend to be the same in those types of communities. So my view is that the quality was a little mixed initially, but the newer research and the better research, frankly, shows that con harms quality. And then finally on cost. So here's the big one. I've looked at 20 peer-reviewed studies. Exactly one of them, in a very roundabout way, finds that con might reduce cost. But let's be clear about what it actually found. They actually include con in the regression to see if it affects costs, and they didn't find any direct effect. All they found is that states that have con laws seem to grow the number of hospital beds at a slower pace. And then hospital beds are found to be associated, fewer hospital beds are found to be associated with spending less. That is not a strong finding. That is not like a finding that con reduces cost. One point I try to make here is, again, go back to Econ 101. If you're going to restrict supply, there's really no circumstance in which you could possibly imagine that that's going to reduce the amount that we spend on a procedure, right? And so why would they even claim this? Well, cost, as you and I and as economists think about it, it's a per unit concept, okay? So if you want to know the cost per of pizza, you think about it as cost per slice. When you talk about the price of gas, it's the price per gallon. And if you want to know the cost of a well-child checkup or a hip replacement, it's a per checkup per hip replacement. You need to think of cost in terms of units, because you want to know what's the financial sacrifice that I get in exchange for this thing of value. There's no reason to believe that con will reduce those types of costs. It is, but if you listen closely to con advocates, they often don't talk in those terms. They don't talk in per unit terms. They talk in terms of how much we spend per patient or per person. Now, in this case, it's totally theoretically possible that if you outlaw healthcare, we'll spend less per patient, right? We could spend less per citizen if we say that you cannot have any hospitals anymore in the state. But it's pretty obvious that that's not really good for patients. So what I would encourage people to think about is when they hear the con advocates, listen closely. Are they talking about costs as the way humans think about costs in terms of the cost per unit? Or are they talking about how much we spend per patient? Because if you're trying to limit spending per patient, that's just rationing, and that's not really an effective way to increase patient welfare by any means.
That's super helpful. I will feel much more equipped next time we face those con advocates. So thanks so much, Matt. And then Maura, I'm going to turn to you. I mentioned when I introduced you that you work to see legislation pass in West Virginia. I'd love to know and hear about what role you think activism played in that process.
So activism was everything. So West Virginia, for either 9 or 12 or 16 years, depending on what you counted as the start of the effort, the West Virginia Advanced Practice Registered Nurses had been trying to achieve full practice authority. And what that is, Advanced Practice Registered Nurses is a group of 4 healthcare professionals, mostly with master's degrees: nurse anesthetists, nurse midwives, nurse practitioners, and clinical nurse specialists. And full practice authority means that we can practice our profession without being supervised or regulated or controlled in some way by a physician, that we are all trained to independently do what we do, but many states require us to have some sort of oversight by a physician. And oversight is not the same thing as cooperating or collaborating or sharing information. I mean, all healthcare professionals should be consulting each other as needed. But so West Virginia advanced practice nurses had tried for many years to get rid of this supervising the lack of full practice authority. And finally, by building a coalition so big, including Americans for Prosperity, including AARP, including different healthcare advocacy groups, including many, many consumer groups, finally built a coalition that the legislature just couldn't say no to. And so the full practice authority bill passed both houses easily. So that was very empowering for me to see, and several nursing publications have now got research articles about the so-called West Virginia model: make a coalition so big that people have to get out of your way. So this has been very useful to me as I think about, now I'm in Michigan and trying to make the same thing happen. Michigan is much more complicated, and one simple bill will not take care of the multiple barriers to full practice authority that we face here. But I realized, this is a great combination of sharing data, building relationships with legislators, and then building the huge grassroots coalition. And so the power of sharing stories became very evident to me. And one of my roles was collecting stories from different APRNs and making them into something that legislators could look at and go, oh my goodness, what? So I'm not a story person, I'm a data person, I'm a policy wonk, but I realized that, as I think Matt was saying, legislators, more of them are more likely to respond to stories. So I realized that this is the thing that needs to happen. So ironically, once I left West Virginia after we passed the great bill, I came to Michigan and we passed 2 really exciting bills. So in the span of 10 months, I had a big role in 3 bills. And then since then, I just worked hard on a bill in Michigan that I passed both houses and our governor vetoed it. This was another, to me, so analogous to the con. This one was about joining the Nurse Licensure Compact, which is the compact is an agreement that says that nurses licensed in certain states can take their license and travel. In Michigan, we have a nurse in the legislature who's been the big advocate of this. And interestingly, one large group of legislators said, oh, well, no, we couldn't have that for nurses because it would be a safety concern. But that same group of legislators voted to allow physicians into the physician licensure compact. So let's talk about what was really happening here. It clearly wasn't really about health and safety. But you know, when something like that happens, I think we all know you go back and you build your coalition bigger, you dig deeper and try a new approach. So my experience in West Virginia led me to be always thinking about what is a legislative solution to this? What is a policy solution? I love the idea of litigation solutions. This is, I come from a legal family, so I'm so excited about the possibility of partnering in the future to get rid of con laws. For example, in Kentucky, I know many of the key players, and I'm excited to see what we can all do using all these approaches.
That's really interesting. You know, the birth center and the con issue has come across my radar a few times, and I've had the opportunity to speak with quite a few midwives. And I think y'all are a very special bunch. Y'all organize very quickly and are very passionate. And so it's a, you know, it kind of lends itself to organizing for legislative change as well.
You know, I have to say, I mean, I've been in touch with a friend who's a midwife in Zambia, Africa. We've known each other for 4 years. We met, you know, at a midwife gathering in 2015. And I just realized that she needs money to educate midwives in Zambia. It's $664 for a year of midwifery education. So I mean, that's nothing by US standards. So that's what I spent the last 2 days doing, is working with my colleague to like get this moving. And we both said, oh, this is just what midwives do. I mean, in the space of a couple of late nights, you know, we're making it happen, it sounds like.
Yeah, that's amazing. Well, I recently saw an op-ed, I think Angela shared it in the last panel, published in the USA Today, discussing maternity care and how the pandemic has shed light on how women are limited on their access and their choices of where they give birth. And so in that, they talked about certificate of need. So how receptive do you think, and the article referenced some research showing this, that women are having less safe deliveries and things. How receptive do you think legislatures are to this research? Do you think there's enough research on the topic?
Well, you know, there has been ample research about, for example, the safety of the birth center model. I mean, going back to, I think the original birth center study published in the Journal of the American Medical Association was in the 80s. So we've had phenomenal amounts of research showing excellent outcomes for decades. And I have to say, as somebody that has stood in capitals and talked to legislators, that's not necessarily what they're looking at. I think anybody knows who's been, you know, aware of people swayed by special interests. I think Matt in particular was talking about when you have a whole array of hospital people there. I've seen people with data get easily shouted down by people saying, oh no, we're worried about safety. And I mean, as I think it was also Matt who said, legislators here, people will die. I mean, verbatim, I've heard that on the floor of state legislatures, and it's not even true. So it's, you know, we feel in the birth center world that we keep collecting data and showing it in different ways. We've done, the birth center world recently did the Strong Start study, which was federally funded. It showed that the model of birth center care was particularly effective, especially with women who participate with Medicaid. So now, luckily, we've got millions of dollars to analyze and publicize the research. So I keep being hopeful that somehow it'll take hold and persuade people that, like, yes, this is actually really safe. But when you're up against hospitals saying, oh no, we have the only thing that works, and what if something happened? Even though we have data saying actually the vast majority of the time when something happens, you know about it. I mean, those of us who are birth center midwives, we're so careful. You know, anything even seems to be going remotely wrong, you're on it, you make a plan, you transport to the hospital. It's not like things just all of a sudden go bad, boom. But it's in a roundabout way of saying, I'm hopeful, but research doesn't seem to necessarily do it. Sometimes people need to have their feet held to the fire in other manners.
Right, right. Well, seeing the publication of this op-ed and just the issue of birth centers, the profile is increasing. So I hope to see change in whatever way possible, whether that be litigation or legislative push. So at this point, I would love to open it up and see if there's any questions from our audience.
I might just follow up on that point really quickly. I was thinking about what Moira just said and what Matt had said earlier, just about some people are numbers people. I think humans overall, we're told, are more, we're story people. We respond well to stories. And I think that's a nice thing. And there's a lot to be said for that. But I think the unfortunate thing is a lot of times we find that legislators in particular are responding to stories above research. Like you can have all the research in the world and all you need is one person coming in saying, but people will die. And then the research just goes out the window. And so I wonder if there's a way, to sort of weave these things together better. It's funny that people tend to be either research people or story people. I wonder how we can do better together. And on that note, I commend to you in a self-interested manner our report that we released today that I co-authored with Angela, because it really does seek to do that. It uses it conducts research and explains research in the context of an entrepreneur in Kentucky, and it really tries to weave together the story of one person and what he was able to do for himself and his community right alongside the research. And so anyway, it's just food for thought. Maybe we're all doing it wrong. maybe the story people are too story invested and the research people are too research invested. And I wonder if there's a way to better meld these things together.
I'm so excited about that. What the model you just described. I'm going to dive into that. Thank you.
Yeah, something that's sticking out to me in my mind is how we've talked at length about how there's just not an appetite right now for to do con reform because the hospitals, the legislature is, like we said, kicking them when they're down. Does anyone have ideas on how to overcome that?
I think it's important that we just have to build grassroots. We have to build broad coalitions and come at this from different angles. I think that as Anastasia pointed out before, stories are so important, and intermingling research with stories is very important. And if we have lots of different people coming forward saying this needs to happen, I think that then you're kind of drowning out what legislators are hearing from the hospitals. So at IJ, we're focusing on grassroots quite a bit in this space. We think that that's the way to combat these special interests here. And we're just trying to explore all kinds of different ways we can reach out to different organizations and see how we can find different people to support con reform from different angles.
One thing I'd suggest, again, going back to kind of the Milton Friedman idea that change happens during a crisis, is to think more broadly. My colleagues and I have suggested that states adopt what we're calling a Fresh Start initiative. And it's broader than just con, but this has obviously been a pretty incredible 12 months in terms of, we all know that states have increased their regulation of personal behavior in many ways, but they've also, it's been extraordinarily in the speed and the scope of the deregulations, everything from allowing nurses and nurse practitioners to practice in states without a license in the state, to relaxing rules that stood in the way of telehealth, to relaxing con, to making it possible to deliver alcohol, straight to your house. There's been all these deregulations, and I think it's a pretty extraordinary admission by policymakers that maybe these rules are not working. And so let's take advantage of this opportunity, and it's a rare opportunity where special interests are a little bit on their heels, I think. And so what I would suggest is take a page from something like the BRAC commissions. So as you probably know, military bases have that same dynamic of concentrated benefits and diffuse costs. So for decades, generals had said we have hundreds of obsolete military bases that we ought to get rid of. But they were blocked because the legislators in the districts that housed the bases always blocked them, not for any strategic reason that served the public, but because they employed people in their district. And so the BRAC Commission really was a very clever design that turned the concentrated benefits and diffuse costs on its head. So what they did was since individual legislators are part of the problem, they are beholden to the special interests. They allowed the legislators to sort of duck the responsibility. They allowed legislators to take a high profile, conspicuous vote in favor of reducing spending. And then they kicked it over to an independent commission. Generally, it was former legislators, former military staff, to actually decide which particular bases would be closed. And then they made it difficult for the legislators to countermand the recommendations of the BRAC Commission. So you basically, again, the two characteristics are allow legislators to cast a conspicuous vote for the general interest, and then allow them to take some cover as they take away special interest privileges. I think we could use some of that same kind of dynamic in Fresh Start initiatives, in panel commissions in the states that evaluate the rules that were eased or suspended during the COVID crisis, and give them the remit of reducing red tape and make it as best as possible, kind of tie the hands of the legislators to make it hard for them to counteract the advice of the commission. So I think that would be my suggestion for sort of taking advantage of this moment. And we may be even passing the stage where we could have taken advantage of this moment. I think a few months ago would have been even better, but I think it's still possible now.
I think it's interesting, we have so much between all of us. We have so many stories, so many great stories, and so much research, just an incredible amount of research with nothing on the other side. And, there's so much there. It feels like we need one central place for all of it so that it's an onslaught. And I'm thinking about things recently that were able to get a lot of attention, and it wasn't successful, but something that's coming to mind is just Serial, the podcast. How at that time, everyone was so into Serial, like every single person. Have you listened to the latest episode of Serial? Do you think Adnan did it? I mean, it really captured the hearts and minds of everyone. And anyway, this is just off the cuff, but I'm thinking now, you can imagine like a podcast like that with stories upon stories of people like Ursula or Mark in Nebraska, all these people, and Moira and her fight, and what happens in the legislature and the legal context and the research and all of these things that every single person here brings to bear in their experiences, and putting it in one place where it's irrefutable and powerful. And anyway, I guess this is just getting back to the idea of sort of harnessing all of our power together instead of working independently. I think there could really be something there, because I know I'm biased, but certificate of need to me is just one of the most interesting and important issues right now. And I think if we all work together, maybe we can create something big that gets a lot of attention.
I think that's a really great point, Anastasia. That seems like a very appropriate, also kind of concluding thought. So I will give audience members another chance to ask questions. But if there aren't any, then I will hand it back over to Anastasia. I think is going to share a few closing remarks.
Well, I don't have much other to say except to be extremely grateful to everyone who spoke today and who attended. And I hope this is just the beginning of more discussions between us, and maybe the start of a coalition or idea sharing place where we can work together to make this issue even more public than it has become in the past year. So with that, thanks so much. And I hope we'll be in contact in the future.
Thanks, everybody.
Thanks all, appreciate it.
Thank you.
Thanks. This was a wonderful event. Everybody have a great day.
Same to you.
Same.